Good afternoon, everybody, and welcome. I'm Austin, CEO of Different Strokes, and I'm delighted this afternoon that we're joined by Anna Kuppuswamy, Principal Research Fellow at the Institute of Neurology at UCL, to talk all about fatigue. This afternoon's session is the latest in a whole week of webinars for our Different Strokes virtual conference. And first of all, I'd like to start by thanking Bolt, Bird and Kemp for sponsoring all the events this week. If you've joined us before, it's great to see you again. And if it's your first time today, thank you so much for being with us and welcome. Now, just a couple of housekeeping things before we start. Firstly, this session is being recorded, but everyone is viewing in complete anonymity. The only people that will appear on screen are myself and Anna. Towards the bottom of your screen, you'll see some functions there. Please do use the chat function to say hi to us for any general comments you've got, to let us know where you're watching from. It's always good to know where all our viewers are. You'll also see a Q&A function at the bottom of the screen. So if you've got any specific questions on the area of fatigue for Anna, please do pop them in the Q&A. And then if we're able to answer them, we'll do a little bit of a Q&A session after Anna's done her presentation. That's all I really want to say by way of introduction. As I said, I'm absolutely delighted to have Anna with us, and I'll hand over to yourself, Anna, to talk all about fatigue. Thank you.
Thank you, Austin. That's great. I'm very excited to be here because it's always fantastic to connect with stroke survivors and discuss with them and get more feedback, and also inform my research with the feedback that I get from stroke survivors. So I'm very glad to be here, and thank you for inviting me to present at this forum. So I'm going to go straight into my presentation. I'm going to start sharing my screen. Okay, so today I thought I should talk quite broadly about fatigue and start focusing on some of the work that we've been doing in our lab to try and understand what causes fatigue. So I'm going to divide my talk into three sections. So I'm going to start off with talking a little bit about what we generally know about fatigue and what sort of studies that other groups have been doing and how much we've progressed in the last few years. In the last 4 to 5 years, there has been a flurry of activity in trying to understand post-stroke fatigue. It's definitely become it's becoming more and more of a problem, and Stroke Association surveys have shown that trying to understand and solve post-stroke fatigue is becoming a top patient-led priority. So there's definitely more focus now amongst research groups to try and understand post-stroke fatigue. So what do we know about fatigue to date? I'm going to start off by defining post-stroke fatigue. It is, well, I'm sure people who do experience it firsthand probably have a lot more ideas about what it means and what it feels like for each person. However, for purposes of research investigation, we need to try and not necessarily condense it, but try and capture the whole essence of fatigue and have an operational definition of fatigue. And researchers over time have tried to do this, and there are some key features of post-stroke fatigue that have been identified. The first thing is overwhelming tiredness. So it's not something like what it was pre-stroke, where you feel tired but not necessarily drowning in fatigue. Let's put it that way. So the first key feature is that the sort of overwhelming nature of the tiredness. And the second is it is persistent, it is chronic. It fluctuates, but not necessarily on a moment by moment basis. And it's not like post-exercise fatigue. And another key feature is that it comes on without warning. I think that's the main difficulty in trying to understand where the fatigue comes from, because there are no triggers or known triggers that are generalizable across stroke survivors, where we can pin down, okay, this activity leads to fatigue, or this is what underlies fatigue. So it comes on without warning. And again, it's not relieved by rest. I've heard so many of my patients tell me that they've had a good night's sleep and yet they don't feel refreshed. So sleep is non-refreshing for people who suffer from post-stroke fatigue. And again, it has a very wide-ranging impact. For some, it impacts more on physical activities and some more on mental activities. And there is another byproduct of fatigue, which is this profound feeling of loss of control over activities and generally life itself. The reason being, it does come on without warning, and the inability to predict what they can and can't do is another key feature of post-stroke fatigue. And there have been lots of different definitions, but I do like this definition that was proposed in 2004 for purposes of trying to understand the underlying mechanisms. So Chowdhury and Behan proposed that fatigue is a feeling arising from difficulty in initiation of or sustaining voluntary effort. So there are some very important points that they have raised here. They use the term voluntary and they use the term effort, as opposed to force and as opposed to just activity. So it does affect volition. So it isn't that one is incapable of performing an activity, but there is some barrier to performance of an activity which is unrelated to the actual motor capability of the individual. And I think effort does play a huge role in fatigue in terms of the defining feature of fatigue. Okay, so that's to do with the definition of post-stroke fatigue. And if you're wondering about the prevalence of post-stroke fatigue, here is a very nice study by Cumming et al. In 2016. And what Cumming et al. Have done is they have summarized all of the studies that have been done with regards to how prevalent stroke is. Now, I won't go through all of them, but what I would like to draw your attention to is this last column here where it says percentage fatigue. And in this column, which is named N, it tells you the number of participants in each of the studies. So as you can see, some of them very small numbers, 13 participants, but some of them very large numbers, 220, 282, 333, 500 participants. And the variability in the incidence of fatigue is also quite huge. So you've got 85%, but again, that's in a small study. And then you can get to 60% and 333%, 33 stroke survivors, and all the way down to lesser numbers of 30%, 25%. This large study says 25%. But again, looking at time post-stroke, that also changes how prevalent fatigue is. But the bottom line with this particular figure that I wanted to highlight is that fatigue is actually very highly prevalent, and it's more common than most people understand. And it's also a thing about when you first have your stroke, do doctors tell you to anticipate fatigue? That is one of the key features that comes out of the study. It has a high prevalence, and we do need to be aware and warn people about fatigue that can last for months. And this second plot is about age. So is fatigue or post-stroke fatigue equally prevalent amongst the different age groups? Now, on the y-axis here, we've got the levels of fatigue. So greater the number, higher the fatigue. And here they are working out, it's the age group. So the 30s, 40s, 50s, and so on. And we can see that there seems to be a sort of bimodal distribution. So the prevalence of high levels of fatigue seems to be higher in the sort of in the 40s decade and the 80s, and then there is a bit of a dip in between. Again, there have been various factors looking at what might be influencing this sort of double dip. We won't go into the details of it. I just thought I should put this slide up so you get some idea of what's the sort of age distribution of fatigue. And here are a couple of plots about studies where they were looking at overlap with other comorbidities, specifically depression, pain, and sleep problems. So normally fatigue does occur in conjunction with some other problems such as depression, pain, and but we also know that fatigue can be an independent problem. So it does occur independent of depression and pain and sleep problems, as highlighted by these two relatively large studies where there is some overlap, but still fatigue is a problem on its own. And again, A 2015 study tried to look at early fatigue and late fatigue. So stroke survivors normally have fatigue that occurs quite early on, but this isn't specific to stroke. Anyone who has been through a life-changing event like stroke would be tired until they've recalibrated to their to the new normal, so to speak. So early fatigue, but there's something called late fatigue, where it sometimes persists 3 months post-stroke. And in some people, funnily enough, there may not be any fatigue in the first 3 months, but late fatigue can develop post three months post-stroke. And there is a huge overlap between early and late fatigue. The circle here that's termed A is representative of early fatigue and B is late fatigue. That's I think it's really important to make this distinction, because the mechanisms of what drives fatigue in the early stages of post-stroke is very different to the mechanisms that drive fatigue in the late stages. And I also thought I should talk a little bit about fatigue and fatigability. So these are two separate constructs. So fatigue is the self-reported version of fatigue, whereas fatigability is to do with how much of activity are you able to sustain over time. And this nice paper in 2013 has basically tried to make the distinctions of where the perceptions of fatigue or self-reported fatigue might originate, and what are the underlying mechanisms of performance fatigability. And they are quite distinct, but there are also overlaps. I won't go into details of this, but I thought I should introduce this idea of the distinction between fatigue and fatigability. All right, so I think that's enough for the background on what we know about the distribution of fatigue, the severity of fatigue, the sort of occurrence of fatigue early and late. So what causes fatigue? And here we're going to focus only on the late stages post-stroke. And I thought this would give us a sort of overview of what happens post-stroke. Stroke results in acute brain inflammation. And inflammation seems to be the start of pretty much all of the problems that we see, especially related to affective disorders post-stroke, be it depression, be it pain. Inflammation has a significant role to play in development of these symptoms. So what happens immediately post-stroke? You have acute inflammation, which then results in changes in cortical neurophysiology, and by which what I mean is there is a cascade of events that results from the neurons dying as a result of losing their blood supply, which then results in lots of chemical imbalances. But all of this gradually normalize over time. Homeostatic mechanisms or the sort of equilibrium mechanisms in the brain will kick in. And 4 to 6 weeks post-stroke, these mechanisms are responsible for bringing your brain back to the new normal. So while this process takes place from 4 to 6 weeks, or sometimes 8 weeks, there is a lot of experience of fatigue, which we call early fatigue. And the expectation is that once the new equilibrium is reached, there will be a reversal of altered cortical neurophysiology. But what we are proposing is that in terms of fatigue, despite the equilibrium being reached, some of the altered neurophysiology does not return to its pre-stroke levels. And what these mechanisms are is what we are interested in finding out. So which of these pathways do not return to the equilibrium point? So the non-reversal of altered physiology or failure of homeostatic mechanisms then results in long-term fatigue. So if you're able to identify what these mechanisms are, then we might start to think about how we can reverse this, given that there is no immediate reason for the altered physiology, such as acute inflammation. Okay, so one of the ideas that we have proposed in our lab is that this altered perception of effort in relation to a particular activity is what has changed post-stroke, which then results in pretty much every activity feeling more effortful, which then gives rise to fatigue. And what do I mean by perceived effort? So this is just a pictorial representation, it's not actual data. Now, if we were to plot difficulty level of an activity on the x-axis, so closer to the left end of the axis is simple activities. And when I say simple activity, I'm specifically referring to simple physical activities, simple motor actions. For example, just sitting here and talking and being able to hold my laptop in place would be considered a simple physical act. And then gradually the difficulty level increases. And if you were to plot that against effort levels, so how much effort is it taking for me to keep my laptop in place? Mind you, this isn't the exact actual energy expenditure, but it is simply the estimated effort or what I feel I need to invest to keep this laptop in position. So that's perceived effort as opposed to the actual force that is being expended. If you were to plot this, what normally you see with people with low levels of fatigue is there is a gradual increase in a perceived effort in relation to increased difficulty levels. However, when there is an altered perception of effort, it very specifically influences low force activities or activities that require very small levels of muscle activation. And what we find in people with high fatigue is there is a disproportionate increase in perception of effort in relation to low force activities, but this does not necessarily translate into high force activities. And you can imagine this as being able to, just brush your teeth, comb your hair, put your clothes on, just doing normal activities feels way more effortful than if you were to perform an activity that required more muscle force. There's a disproportionate attribution of effort to low muscle forces. So therefore, activities of daily living require more effort. Now, in what we recently showed in a study that we conducted in our lab, we tried to quantify this in a physical task. So what you're seeing here is on the x-axis, you've got fatigue levels, and there are 3 plots here which correlates with the perceived effort in relation to a low force task. And the task was basically a hand gripper. We asked people to grip as hard as they can, and then we calibrated to each individual's maximal force, and we asked them to perform 20% force task, 40% of the maximum, and 60% of the maximum. And then on the y-axis, we asked them to rate their perception of effort for each of these different force levels. And what we found is the greater the fatigue, higher the perception of effort, only in low force tasks and not in the medium force and the high force task. And this confirms the idea that there is a disproportionate increase in perception of effort related to low force activities and not necessarily in the high force activities. Now, this gives us a handle on what might be going on in the brain in terms of how effort is represented. So normally, the brain tends to ignore the efforts that it invests in low-level activities, and that's why we are able to lead our lives without actually feeling the full force of the muscle contractions that we do on a daily basis. But if this mechanism is broken, then we can explain the perception of high efforts in people who suffer from post-stroke fatigue in the chronic phase. So the second idea, the second mechanism we think is driving post-stroke fatigue is the inability to focus on targets or information that is relevant to a task and ignore the information that is irrelevant to a task. A lot of my patients have reported that they can no longer walk into a bar, they can no longer attend a party, they can no longer go to weddings because of the extreme levels of sensory stimulation that goes on. So there is a sensory overload, they're unable to focus on conversations, and that triggers their fatigue as well. So which led to the idea that there might be a problem with selective attention. And what do I mean by selective attention? So what happens when you're seeing this picture on the left is basically, lots of different signs, it is crowded, and how does the brain process information is, it's the picture on the left. If I'm interested in finding out where the motel is, my brain would sharpen the perception of the target stimulus, and it will dull the perception of the distractor stimuli. So this is how the brain is able to cope with sensory overload. But what we are proposing is in people with post-stroke fatigue, their inability to filter out irrelevant information is probably leading to this sensory overload. And we have now recently tried to study this in our lab by doing a visual perceptual task. Again, similar to this picture that I've put up on the slide, we asked people to focus attention on a stimulus, and there was an active task they had to perform by looking at the target stimulus, and we started increasing the load of the stimulus, the amount of attention that is required to perform the target task was increased in terms of the task difficulty. And we had lots of distract stimuli to see if people with fatigue process distractor information different to the target information. And I'm just showing a plot here. Again, we've got fatigue on the x-axis. On the y-axis is a measure of how much the distractor is being processed. And this is a brain EEG study. So we were directly recording brain activity using electroencephalography, and you can start measuring the power of different frequencies, which gives you some idea of how much the distractor is being processed. And what we have here is there are two lines here, the red and the green line. And what we did was when compared to the low load for the target stimulus, remember I said we tried to increase the difficulty of the task. So when the difficulty was low, people were able to perform in the same way. However, when they moved up to the medium levels of difficulty for the task, the people with high fatigue were unable to move away from the distractor to the target stimulus, and similarly for the high task difficulty when compared to the low task difficulty. And this is basically a measure of brain processing power. So what we initially proposed appears to be true, which means the brain is unable to switch attention from the distractor to the target, which then explains high levels of effort and the inability to filter out noise, so to speak. Okay, so that's just a quick overview of a couple of studies that we've done trying to understand the driving mechanisms of fatigue in chronic stroke survivors. So the big question is, how do we tackle fatigue? Yes, there's been quite a few studies trying to understand, trying to look at what are the possible treatments for post-stroke fatigue. The first line of inquiry was looking at pharmacological treatments. So they said, oh, let's look at antidepressants because we have fatigue and depression seem to occur together. So if we get rid of depression, maybe we can get rid of fatigue. And they were wrong. There's been quite a few studies, first one looking at fluoxetine, and there was no effect. You can see it says NS. NS means non-significant effect after 3 months of treatment. And during the follow-up, it's one of the commonly used antidepressant, and the same with duloxetine and sertraline. Again, I've highlighted the fatigue scales. There's really no difference in fatigue levels using antidepressants. And there's been some success using modafinil. Modafinil is a wakefulness promoting agent. So it's a dopaminergic drug which increases arousal levels, and there has been some moderate effects. And a slightly larger study has shown that there are some beneficial effects for using modafinil for improving fatigue. That indicates significance, the p-values, and then we can, but the effect sizes were quite small. And more recently, I haven't put that up, 2021, there's been a study where they've looked at why are the effects so small? Can we categorize patients based on what types of changes in the brain might predict a good response to modafinil? And they do find that when you have more frontal striatal disconnection, then modafinil tends to have a much better effect. So that's all fantastic. In our own lab, we have tried looking at increasing cortical excitability. So brain, So the brain states can be very different. So we define brain states based on their excitability. So if we were to try and stimulate my brain, we can tell if my excitability levels are low or high. And what we found in a previous study was that people with high levels of post-stroke fatigue had low levels of excitability. So we thought, oh, well, let's increase excitability and see what happens. And here, what we did was it was a sham control study. We did the real TDCS stimulation, which is a form of non-invasive brain stimulation. And we also did sham stimulation, sham group. And we recorded fatigue levels a week after stimulation and a month after stimulation. And you can see this was the baseline levels of fatigue for the two groups. There was a reduction in fatigue, but not necessarily significant when it comes to the sham treatment, whereas with the real treatment, we did see quite a bit of a difference. So in this plot here, we can, the zero is the baseline level of fatigue, and this is the difference in fatigue using sham treatment and real treatment. So that's quite promising, but we still need to work out, again, do some people respond more, do some people respond less, and what are the mechanisms of it? And another study, this is now a bit of an old study now, but I don't think they have taken it forward in terms of developing treatments based on it. What they show is cognitive behavioral therapy and graded exercise have been shown to be quite effective in combination. And so we've got T0, which is the time when they started treatment, and this was when the treatment stopped. And this was, I believe it's a 6-week follow-up and a 3-month follow-up, where there is a significant reduction in fatigue scores. So cognitive behavioral therapy and graded exercise, mind you, these are not strength training, and it is not, it is about gradually increasing activity. So these appear to be quite helpful. And of course, in the meantime, if we are thinking about how do we manage fatigue, there have been studies looking at different types of management. So the first is, there appears to be something about dividing up the stored energy for the different activities you need to do throughout the day. And if something unplanned occurs, then that seems to trigger fatigue. So planning seems to be a very useful technique for many of my stroke survivors, and some of the other studies have reported that is helpful in managing post-stroke fatigue. And so planning ahead of time. And of course, the second technique is pacing and chunking. So in 1 hour of work, I'm going to work for 20 minutes. I'm going to take a 5-minute break, another 20 minutes and a 5-minute break. So chunking or pacing your activity has proved quite useful. And of course, recalibration, I'm not sure how much you would agree with me that it is a strategy for managing post-stroke fatigue, because that's basically lowering your expectations of what you want to do during any given period in time. So that's again, some people have managed to use it successfully to stop fatigue from being triggered. And of course, stalling has been reported in the literature in terms of people saying, okay, it's going to get better tomorrow, so let's start putting everything for tomorrow. And that's, I wouldn't say it's a great strategy, but it's again something that people have tried to do rather unsuccessfully. So I think planning, pacing, and chunking are probably the two most effective strategies to manage fatigue that's known to us so far. But hopefully the treatments that are in line will help improve fatigue way better than what we are currently managing. So to summarize, chronic fatigue after stroke is highly prevalent, and I think it's being given the recognition both clinically and scientifically in the last 3 to 4 years, so which is great news, I think. And we believe that altered sensory processing might explain fatigue. And by sensory processing, what I mean is sensory information, both visual information, auditory information, and information from contracting muscles in the body, all 3 types of sensory information being misprocessed, which then explains the high levels of effort in relation to various types of tasks, which then gives rise to fatigue. And there are some pharmacological, behavioral, brain stimulation interventions that are showing promising results. So I think I will stop there. So that's the effort lab. So we've got some PhD students, postdocs, and master students working on a lot of the projects, and hopefully soon we will have more results. And some of the collaborators and the Wellcome Trust and Royal Society who fund my lab. Right. So before I stop, I would like to advertise the UCL World Stroke Forum Day, which is happening next week between the 25th and 29th of October. And there's a whole range of events. So you, if you're interested, you should sign up. There's some very exciting events. We have been involved in a public engagement project where we have developed artwork in collaboration with our stroke survivor participants to portray the sort of lived experience of fatigue, because it's all well and good for me to talk about fatigue, but how does it feel to be in someone's shoes who experiences fatigue? So we have brought patients, artists, and scientists together to develop this artwork, which we're going to be premiering next week. It's on the 27th. So if you want to sign up, this will be your opportunity. So there's still some places left. So here's the information for that. Anyway, thank you so much for your attention. I am going to stop rattling on, and I'm happy to take any questions now.
Anna, thank you so much. That was absolutely fantastic, and it's great to hear about this and everything that's going on. We've had quite a lot of comments in the chat and some questions come in, and a lot of comments have been along the lines of there's been a lot of information here, and I know that there's been so much here that a lot of people are taking it quite difficult to take it all in at first go, but hopefully with the recording...
Sorry, I just crammed it all in.
It's fine, it's great, and hopefully obviously this session is being recorded and it'll be available within a week or so, and hopefully people then will be able to come back to it and watch it one or two more times.
Let me stop sharing my screen, because there we go, that's better.
It's been fascinating to hear about all the research that's coming in. The questions that we've had both in advance and on the day are much more focused around the living with fatigue side. I know that's of particular interest to the majority of people watching today. So I just wonder if you could elaborate, first of all, a little bit more on the strategies to reduce fatigue.
Yes, so in terms of strategy, I think, okay, the first thing we need to remember is we need to start identifying the triggers for fatigue that is quite individual to each stroke survivor. That's the one thing that I've learned. So for some people, I know stroke survivors who scored very highly on the fatigue severity scale, however, are able to run a marathon, but cannot focus on a conversation. So here there is quite a clear distinction between what triggers fatigue. It is about the sort of the information processing in relation to visual and auditory information. So the first thing to do is try and identify what the trigger for your fatigue is. And then once we identify the trigger, then we can start looking at eliminating the different ways of how we can manage, or what works and what doesn't work for someone. So trying to avoid spaces that are crowded, trying to avoid doing things continuously, and basically seeing what works for each person. So I think that's probably as far as we can go in terms of how we can try and manage fatigue. We are a very long way off giving tailored programs for each individual, but I know that therapists are doing a great job in trying to identify sort of physical techniques. And like I said, the sort of pacing and planning, I think these are the two key currently available management techniques. And like I said, I think planning really works. And I know people who say, well, I've just had to do this one extra job and everything just goes completely off balance. And it's about how much can you actually control what it is that happens during the day. So it's a balance, it's a trade-off between trying to avoid triggers and actually being able to lead a meaningful life.
Thank you. Question that's come through today is, what are the normal and exceptional bounds of fatigue?
Okay, so the one thing we have to clearly understand is the fatigue pre-stroke is very different to fatigue post-stroke. So so basically the definition of fatigue pre-stroke is to do with fatigability. The repetition of an activity leads to greater levels of effort and fatigue, which is then reversed by rest or restoration of energy. Whereas when you talk about post-stroke fatigue, all of these players simply go out of the window. So we have a completely different definition of fatigue, which is more to do with not necessarily repetition of an activity, but the context in which the activity takes place, the brain state in which the activity takes place. So the rules of the game completely change when it comes to defining fatigue pre and post-stroke. I don't know if that answers the question.
Okay, thank you. We've had a couple of questions have come in regarding work. Yes. You know, there's been a comment that it's hard to know if we're ready for work, and also we had a question about coping with fatigue and work and what can be done regarding this.
I'm not sure I'm best placed to answer this question, but I will try my best in terms of the strategies that you can develop to cope with your fatigue will probably help you cope with the work as well. And of course, the first thing is to make your employer aware of the fact that I have this problem of post-stroke fatigue, and I know doing X, Y, and Z is going to cause my fatigue. So can I actually have jobs that can be compatible with my fatigue? And of course, for some people, recovery from fatigue is the biggest issue. So you can push through and then start doing, let's say they do a work on one day, a 8-hour day, and then the next 2 days they're recovering from the fatigue that's been caused by the 8 hours of working. So I guess part-time working is probably the way to go when you start off. And of course, the key thing is to find the right kind of support with employers. And I've had a few issues in terms of how do we, why would employers believe people with post-stroke fatigue? How do we make people aware of this problem of post-stroke fatigue? How are we going to, so we are actually working on the policy side as well. We're trying to make changes to how, to make post-stroke fatigue being recognized by employers, to make reasonable adjustments for employment. But again, it's really at the discussion stage, but we can't really tell where this is going. It's quite hard to negotiate these sorts of deals with employers, but I think that's where things need to change. Because yes, until the day we are able to reverse fatigue and have treatment for fatigue, it's going to be about gaining the support and understanding of people who employ you and your friends and family as well.
Thank you. And I would say on this subject, if people are watching that have a particular interest in fatigue and its relationship with work, we do have a session on work after stroke tomorrow morning at 10 o'clock. So please do watch that, because that may be really useful to you. We've had some questions come in regarding medication, particularly GPs. It's been asked, would we need to see should we see our GPs regarding medication for post-stroke fatigue?
That's really interesting. Like I said, there aren't any completely proven medication for treating post-stroke fatigue. However, modafinil is something that has worked for quite a number of people, and more recent studies have shown good efficacy. But again, it's about choosing who is going to be effective in. I think that we are still awaiting sort of a large-scale RCT to determine how to stratify post-stroke fatigue to see if they're going to benefit from modafinil. However, I know of GPs who have prescribed it just to see if it helps. So I think if you're suffering from very high levels of post-stroke fatigue, then it's definitely worth a shot to talk about, highlight these studies and see what they say, because I think it's definitely not in the current sort of nice guidelines to prescribe modafinil for fatigue, let's put it that way. But that is gathering momentum and evidence for modafinil in some patients, not all. So again, it's a bit of a hit and miss.
Thank you. How do you help with mood changes caused by fatigue?
That's a very tricky question. I don't think we have actually started looking into the interaction. We do know that people who have been diagnosed clinically with depression also report fatigue. But of course, that's not what people are talking about here. Presumably, it's about people who have fatigue, which then results in differences in mood. And we know that fatigue is actually a risk factor for development of depression. So that's why it is critical that we have to start managing fatigue quite early on, so it doesn't escalate into something that is more, well, I shouldn't say more serious, because it is equally serious to have debilitating fatigue. So how do you cope with it? I think the best thing is to try and manage your fatigue and try and avoid triggers for fatigue, so that you don't actually put yourself in a state where you end up with huge mood swings. But I do, I'm sure people are probably thinking, well, it's all well and good for you to say that, but how can you? It's basically to avoid life, otherwise the fatigue doesn't manage itself. So it's a tricky balance, unfortunately.
Anna, we are actually getting a huge amount of questions come through, but I'm not sure we're going to be able to answer them all today.
Okay, yes.
But potentially, if I invited people to email in some of these questions, would you be happy for me to forward them on to you so that you can come back to them?
Yeah, absolutely.
Because we are getting a lot of questions come in, but as I said, I don't think we're going to be able to go through them all, but I'll certainly pick a few more out.
Yeah, sure.
There's a number here that I'll all take together that are centered around the whole issue regarding time. So we've got a question in very general terms: how long is post-stroke fatigue likely to last? It's also been asked, does fatigue improve over time if you keep trying something? And also another question about, have you tracked fatigue improvements over time? Is 2 years post-stroke the best we could be, for example?
Yes, okay, all very valid questions, very interesting, important questions, that some of which we are trying to answer. So in terms of what do we know so far, in terms of how long does this fatigue last? Most studies tend to do a 2 to 5 year follow-up. And recently there was a study, a relatively large cohort, looking at a 10-year follow-up. And there still appears to be about 30 to 50% prevalence 10 years down the line. However, it seems to does get better over time in most people who suffer from fatigue. Again, late fatigue, and I'm guessing the improvement is down to actually better management and understanding their own fatigue and avoiding triggers, rather than actually fatigue resolving in a way that we would like it to resolve. That's why you still have a high prevalence in the 10-year mark. And you have So a lot of the studies have focused on the 2-year mark post-stroke, and there still is quite a high prevalence at 2 years post-stroke. So that's as far as we know. Acute fatigue, yes, there's very high prevalence, and the chronic fatigue either continues 6 months post-stroke, or it starts to pick in about 6 months post-stroke. It seems to peak at 2 years, the reason being probably the studies are skewed towards looking at 2 years post-stroke, but it still persists at about 5 to 10 years. And in a lot of people, it does seem to get better, but again, it's about, I'm not sure if it's reversal necessarily.
Thank you. Would you draw a distinction between mental fatigue and physical fatigue?
Okay, well, this keeps coming up in relation to the studies that we do as well. So what are we talking? The two studies that I presented, one was to do with a physical task, and the other was to do with processing visual information, which will be considered a mental task. So, so what I would say is fatigue is a single construct. It is an experience that arises from some sort of difficulty, either initiation or processing of information. So what kind of information is what is different? So it's the physical information from the muscles, or it is the visual and the auditory information, which then is processed within the brain in the respective areas. So what would normally be classified as mental fatigue is what they actually mean is the trigger is a mental trigger, whereas the experience of fatigue is a single construct, if that makes sense.
Yeah. I think the next one is a question that I'm sure a huge amount of people would resonate with a huge amount of people. Is someone who is suffering from fatigue, should they give into it and rest, or should they try to fight through it? And if they try to fight through it, or does rest exacerbate the issue, or does fighting through it exacerbate the issue?
Oh, okay. Well, this is a very, very tricky question. You're probably going to be very disappointed because it is really down to what the individual, how each individual reacts to exercise. Because we don't know what the mechanism of fatigue is, we can't say that rest is going to improve fatigue or exercise is going to improve fatigue. And I think that is the biggest dilemma, because I know people who have gone to the GPs, the doctors, the neurologists, they have said, oh, well, why don't you rest? And then you end up with muscle deconditioning, you don't exercise, so that then results in more fatigue. So there is this big thing about, do we rest or do we not? I think it's a very Shakespearean dilemma we've got here. But the best advice so far, just based on report, is if you push through the fatigue, it can actually end up making it worse. And it's best not to, but again, there is a threshold for when you can push through and when you should stop. And let's just, just visualize it on a scale of 0 to 10. If you feel that pushing through is going to only push your barrier at the level of 5, then push through. But if you think you're at 10, don't push through. So, or closer to 10. You see what I mean? Yeah. Because it tends to, pushing through has not worked in most people. Let's put it that way.
Thank you. We just got time for a couple more questions. The first one, I think, is a really interesting question that I must admit I never thought of myself personally before. I don't know if you have any thoughts on this, Anna, but no, should we start using a different word as opposed to fatigue? Because as it's a comment here, fatigue just sounds like tiredness to the uninformed, which could compound the problem.
Absolutely. Okay, so just 3 weeks ago, there was a strategy meeting at the National Institutes of Health in the US, and they are drawing up a huge blueprint for studying chronic fatigue across different diseases, not just stroke. And the first thing they tried to pin down is, should we actually discard the term fatigue? Because it is quite misleading, and it actually is an umbrella term for lots of different experiences put together. It's almost like a black box. And it's time to start making the distinction between effort, information processing difficulties, or whatever it is the underlying causes. And I think eventually we are moving towards that when we get a more fine-grained view of what this fatigue, complex symptoms of fatigue is made up of. And then we would move towards better terminology. And I agree completely that we should move towards something like that for purposes of ease, for everyone, for clinicians who are dealing with, for patients who are experiencing it, for everyone else, because I think the labeling things can make things quite difficult, and the label has probably made dealing with fatigue a lot more difficult than what it should normally be.
Yeah. Does a small stroke, presumably a TIA that this question is referring to, can a TIA still result in fatigue?
It may, but there have been studies looking at the prevalence of fatigue post-TIA and post-stroke, but it is very clearly correlated only with stroke, and TIAs don't tend to result in fatigue normally.
Okay, thank you. And I think we'll make this the last one today, Anna. Can having caffeine help post-stroke fatigue?
Oh, okay. Well, I think it's a question of, because caffeine works by increasing arousal, and it's the same thing as modafinil in some ways, so it's less potent. So if you're thinking about sleepiness is related to fatigue, and then caffeine might be effective. But if there is no relation between sleepiness and fatigue in your particular case, then caffeine is unlikely to have any effect.
Thank you. Thank you, Anna, so much. It's been absolutely fascinating to hear you talk today. We've had some absolutely fantastic questions as well. So thank you to everyone who asked them, and thanks, Anna, for taking the time to answer them.
Thank you so much for having me.
Apologies, we've had so many questions and we haven't had a chance to answer them all, but to reiterate, if anyone does have any further questions for Anna, please do send them to us at info@differentstrokes.co.uk. We'd be absolutely delighted to pass the questions on to Anna. The recording of this session will be available within a week or so's time. Hopefully, Anna, if you could also forward the slides, I'm sure that everyone who's watched the session today would be really helpful for that as well, so that would be fantastic. So once again, thank you, Anna, so much. Really appreciate your time.
Thank you very much for having me, and it's been a great discussion. Yes, we always have to start thinking about new ways of looking at things, and interacting with people who do suffer from it is a sort of gold standard. That's what we are doing. That's who we are doing it for. So if it doesn't help people, then there's no point in it. So I'm so glad to have been able to present at this forum.
Yeah, well, no, it's been brilliant to hear from you, and I know that we've had a lot of people watching today, including people in Portugal and Chicago. So it's absolutely fantastic that it's been so kind of widely viewed. We've got a number of more sessions coming up throughout the rest of the week, starting, as I briefly touched on earlier, with another fantastic guest speaker tomorrow morning. That's Kath Wood from Remploy. We'll be talking all about work after stroke. So please do join us at 10 o'clock tomorrow morning to hear Kath, because I know it's going to be another fantastic talk. But once again, thank you to Anna. Thank you to everyone for watching this afternoon and for all of your time. And we'll see you all soon. Thank you.
Thank you. Bye.